The first talk will be on documentation of corneal disease by Professor Dr. Nagaraju Ji, Professor and Head of Department in Minto Ophthalmic Hospital, Bangalore. It is recorded.
Good morning, everybody. At the outset, I would like to thank the organizers of COSCON for giving me an opportunity to hold this PG refresher course. I'll be speaking today on examination and documentation of the corneal diseases. We see a plethora of corneal diseases like this. How do you examine these cases and how do you put it on paper? Of course, you have to do a complete ocular examination, assessment of the vision. Corneal examination includes assessment of the complete patient, including the adnexa, before you come to the slit lamp examination. All the layers of the slit lamp, all the layers of the cornea can be documented, can be visualized by slit lamp examination, and the thorough slit lamp examination is a must before you document a corneal case. And there are various techniques to assess the clarity of the cornea, the depth of the cornea, different illumination techniques to see the thickness, opacities, or the endothelium of the corneas, and you can use special filters to in certain conditions. All these things you have to be well versed with, and of course you have to be well versed with these special tests also when you assess the cornea. And you should never forget to assess the tear film and the lacrimal adnexa, and wherever required you can order special investigations. What to look for in a cornea case? Whenever you see a corneal case, first thing is you describe the cornea, normal cornea. Then you describe the lesion within the cornea if there is a lesion, or if there is an opacity or an ulcer, then you describe that after you describe the corneal ulcer. What are the points you look for in a corneal case? One is the size, shape, surface, transparency, opacity, vascularization, endothelium, and the sensation of the cornea has to be checked in all the cases. The size, whether it is increased or decreased, has to be documented. Shape, whether it is a normal flat cornea like a cornea plana, conical keratoconus, globular keratoglobus, or your irregular keratotorus or your PMD. This has to be looked for. And the surface of the cornea, you should assess it either by a simple window reflex or using a sophisticated instrument like a topography. Transparency has to be checked for in all the cases using different illumination techniques. And don't forget to look for vascularization under a cobalt, under a red-green filter, and document whether there is a presence of superficial, deep vascularization, and also look for pannus also. And this is how the various types of vascularizations appear in the cornea. And check for the corneal sensation either using a wisp of cotton or an anesthesiometer. And endothelium has to be looked for in all the cases to know the extent of the disease. Once you see a case, once you describe the normal cornea, if there is a lesion in the cornea, if there is an opacity in the cornea, try to mention the number of the opacity, the size and location of the opacities, the depth of the opacities in the cornea by optical illumination, the type of opacity, the grade of the opacity, and whether there is any presence of vascularization. This is very important in most of the cases. If you see a case of corneal graft, you describe the cornea, then you describe the graft per se as a separate thing. Then you mention about the graft host junction also. What all things you look for when you see a corneal ulcer? First thing is see whether the location of the cornea, whether it is central, paracentral, or peripheral, dimensions of the cornea, the depth of the lesion on optical illumination, and see whether the ulcer borders are progressive or regressive. Like in this case, you see the ulcer which was progressive. After treatment, you can see the regressive borders, or whether the ulcer has got an undermining edge. And look for look at the floor of the ulcers to see whether it is a dry or whether it has got a dirty slough. That will give you the diagnosis in certain cases. And dimensions are also very important. And the distribution of the ulcer, whether it is a localized ulcer, a diffuse ulcer, or a annular ulcer, or it can be a serpiginous ulcer also. Margins of the ulcer can sometimes help you make the diagnosis of the corneal ulcer. And all the cases, the severity of the ulcer is always determined by the extent of invasion of the cornea. That has to be documented along with the surrounding cornea. Look for satellite lesions, and never forget to do a KOH mount in all cases of corneal ulcers. Once you have seen all these corneal lesions, how do you put it on paper? And it is not that difficult. Basically, documentation, you've got a central zone, paracentral zone, and a peripheral zone, and you've got 4 quadrants in the cornea, where you have to look for. And you don't require any sophisticated instruments. You require just lead pencils, crayons, erasers, transparent rulers, and To draw a circle, either you require a bangle or a trial lens, and of course slit lamp is a must. Draw a circle, draw lines like this to demarcate the different areas of the cornea and draw the pupil at the center. This is your frontal view and this is your slit view. And the lid margins are depicted like this in the frontal view. In our hospital, we use this chart, and the color codes are very important. All of you have to memorize this. All outlines, corneal outline, frontal, slit lamp, slit sutures, lashes, IOL, PK, and RK scars has to be documented in dark black color. Contact lenses in slashed dotted black lines. Scars degeneration gut and corneals has a black color. Edema, blue color. Descemet fold has wavy lines. Epithelial edema has small blue circles. Fluorescence color can be demarcated like a green color, like either as a dot in case of SPK, lines in case of filaments, shades in case of epithelial defects. Vitreous and corneal filaments also can be documented in green color. Pigment and iris, your pupil, peripheral iridectomy, peripheral anticyanic in brown color, blood and rose bengal in red color, blood vessels, whether it is a superficial or a deep vessel, you can make it demarcated as a wavy line or a straight line. And if there is a solid shading, it indicates usually a red hemorrhage, which has to be documented in red color. Ghost vessels can be documented in slashed red lines. And this thing, yellowish color color code can be employed to depict a purulent lid discharge, contact lens deposits, intracorneal abscess, stromal infiltrates, keratic precipitates, hypopyon, and a cataract. Of course, you have to mention the presence or absence corneal sensation in this format, and also don't forget to mention the patency of the lacrimal apparatus, excretory apparatus. And in certain cases, you can use sophisticated topography machines and try to document the same on a sheet of paper. In the normal eye, you can see this case. You can see this is your cornea, this is your iris, this is the lens, this is the lid, this is the normal tear film. And what you see as an isosceles triangle is the tear meniscus. This is how you document the eye on an optical view. If there is an ectropion or a lid malposition, you can see the lid is being shown like ectopion is being documented like this. And if there is blepharitis, you can always put black circles on the eyelashes to indicate the patient has got blepharitis. Uveitis in the frontal view can be documented like this. Dry eye, you see rose bengal stain being marked like this on the frontal view, and you see this isosceles triangle is marked as a, here you see it is just like a small curve, and you can make you can write small dots there to indicate the presence of any tear film debris also. That is what has been done here. In this case, there is a severe dry eye with a fluorescent stain being positive with vascularizations also superficial, which is marked as wavy lines. Vernal conjunctivitis is demarcated like this. Here, Horner Toronto spots is depicted like this. Corneal foreign body, a pterygium in a black color. Herpetic keratitis. Herpetic keratitis can be demarcated like this. Disciform keratitis, stromal edema. You can see the epithelial bedewing here. Bluish stromal edema can be documented like this. Of course, you can see the endothelial involvement there also. Dystrophy in the corneal stroma, an epithelial defect can be documented. Anterior uveitis, you can see here being shown on the endothelium of the cornea. Even a graft rejection, graft also can be demarcated very well like this. A corneal ulcer with surrounding edema and an ulcer. Of course, you can mark this on the optical section view also. An hypopyon corneal ulcer. A marginal corneal ulcer can also be depicted this way. A ligomatous corneal opacity has a black lesion with vascularization, and even you can, if you are very good at it over a period of time, you can even mark the endothelial graft rejection also very well. And just by looking at the diagram, you can just try to, you can picturize what is the probable lesion, and every day a corneal lesion has to be documented in the course of treatment to know whether the condition is progressing, status quo, or regressing. Thank you very much.
Good morning all. A few more points to add. For a PG examination, the probable cases under cornea topic would be pseudophakic bullous keratopathy, or it could be a corneal ulcer. Always first a diffuse illumination has to be done, followed by an optical section and a parallelopiped examination. Even when drawing a corneal drawing, you have to draw the diagram of both a diffuse illumination as well as an optical section. It has to be done using color pencils and should be neatly labeled as well. Later, corneal sensation also has to be clearly documented in all the 5 quadrants. Thank you.
I would like to thank Dr. Nagraj sir for his patient teaching, which is very important from every postgraduate's view as to how to document a corneal case, which in most cases end up being a long case presentation. We will now be moving to the next talk, which is by Dr. Deepthi R. Mehta, who's a consultant cornea, refractive and cataract at Karthik Nechalya. Ma'am will be covering the topic on corneal topography and interpretation of pentacam.
So very good morning everyone. So today let's look at interpretation of corneal topography with emphasis on interpretation of the pentacam. So as we all are aware, the corneal topography can be largely reflection based or elevation based, and we have enough experience now to say that elevation-based topography have very clear advantages as compared to placido-based, which is basically reflection-based. So the area which is captured is much higher in elevation-based, and the main advantage is the analysis of the posterior corneal surface and the global pachymetric analysis, which is almost inevitable in today's refractive practice. So of the elevation base, the pentacam is one of the most popular in India and worldwide. So through this presentation, we'll look at how to get a reliable scan and what are the smaller subtle signs that you have to look at to not miss a FFKC, and also a 6-step guide for interpretation of the pentacam quad map. So the pentacam gives various displays, but in view of time, we would look at analysis of this very important quad map which the patient usually carries. Now, before interpreting any map, it's important that you mentally divide them into areas. So however busy you are in the OPD, you do not miss looking at any of these areas, thereby not missing a case of FFKC. Now, always start with checking the demographics. Make sure you're interpreting the same patient's scan by a manual cross-check with the patient. And also make sure your technician has performed the test right. So the pentacam is a very quick test, a quick scan. So you have the central camera which monitors the movement of the eye, and the peripheral camera which captures the slit photos of the cornea. Now once this is done, this is the overview map where you can actually go and inspect all the 25 or 50 slit images. Now this is a patient, when the scan is happening, look at him move. So if this is the case, then obviously the data that is captured is not right. So how do you pick such errors is basically to inspect as the quality score or QS. So if your quality score is saying okay and in white, that means it's a reliable scan. Anything in yellow and red shows that there is some issue when capturing, and you can always click on this box to get a more detailed analysis, and viewing this you can always correct the mistake and try to get a more reliable scan. Now before again we start, there are a lot of parameters that you need to preset in the pentacam, and it's very important you set the right parameters so that even the subtlest deviation that you want to know is highlighted just by the color scales. So look at case 1 and case 2 on the left and right. Now the upper and lower of the other sagittal curvatures of the same cornea. The only difference is the upper ones are on relative scales and lower ones are on absolute scales. So relative scales are preferred when you're trying to look at smaller irregularities, like when you're trying to look at a pre-refractive pick of a subtle ectasia or FFKC. Now again, 3 anterior and posterior elevation maps. What is different is basically the color scales that they are displayed in. Again, 3 anterior and posterior maps of this very same cornea. The difference is the upper one is 25 microns apart, the middle is 10 microns, and the lower is 5 microns apart. So closer the steps, more obvious are the details. So it's always good to have smaller steps when you're trying to screen FFKC on a refractive screening platform. Now this is the recommendations as provided by Professor Bellin. Now coming to the elevation maps, now like how you compare the level of any topography or any surface on earth, that's always compared to the sea level. So thereby you know where Mount Everest is as compared to the Dead Sea. Now when it comes to comparing the corneal surface, unfortunately the cornea does not have any prefixed reference surfaces. So the machines have to create their own imaginary best fit surfaces, which is the best fit sphere in the pentacam. So for this cornea, the machine has chosen a BFS of 6.66 mm, and the areas of the cornea above this are always in positive and hot colors, and the areas below it are in negative or cool colors. So what are the cutoff? When you're looking at the central cornea, anything more than 12 is suspicious and anything more than 15 is certainly abnormal. And when you come for the posterior surface, it's around 5 microns more than the anterior. So anything more than 20 microns on the posterior surface is very suspicious of keratoconus. Another important point would be at any given point, the anterior and posterior surface, the difference should not be more than 5 microns. So again, when you look at the right side map, in the periphery, their anterior elevation is 16 and 18 and 19. So is it abnormal? Not actually. So all these cutoffs are basically at the central 4 to 5 millimeters. In the periphery, any high elevations like this is okay, and this is called as a saddle pattern of an astigmatic cornea. So it's very important you differentiate between a saddle pattern where your elevations are abnormal in the periphery and the island pattern where the elevations are abnormal in the center. So saddle and island pattern. Now coming to the K readings and the topography maps. So on the left upper corner you have the K1, K2, K mean and astigmatism as in your ARK or auto keratometry machines. So this is again important when you want to have end target K reading of when you're planning your LASIK surgeries. So you don't want your post-LASIK cornea to be flatter than 34 or steeper than 50 diopters to give the best optical clear vision. So coming to your topographic, another important thing would be your K-max. So this is a very important parameter, especially when you're trying to look at progression of keratoconus. Now KPT again is an interesting parameter which the pentacam provides, which is the keratometric value of your posterior surface. So anything more than 1.5 is suspicious of a corneal ectasia. Now when you come for interpreting your sagittal or tangential maps, so you have a lot of patterns that can be displayed. Now the top 2 rows are the 10 standard patterns that have been described, and a lot of other special patterns which I go through. So your pattern analysis basically depends on your symmetry, asymmetry, skewing. The ones which are highlighted in green now are basically the symmetric patterns. So the round, oval and the symmetric bow tie. So if all these patterns are with the K reading of less than 47.2, then you could consider them as normal. But the same round or oval pattern, if steeper than this, then certainly it could be a bank central keratoconus. Now again, when you go towards asymmetric pattern, it is more leaning towards abnormality. So whenever you have a superior and inferior asymmetry in either of these patterns, a superior symmetry steepening of 2.5 and an inferior steepening of 1.5 diopters is suspicious of a corneal ectasia. Again, skewing is the axis between the superior and the inferior hemimeridian, and if this axis is more than 22 degrees, again a sign of corneal irregularity. There are again a lot of special patterns described that could be butterfly, claw, junctional, vortex and irregular pattern. Now coming to the last part of the quad map, that is the pachymetric map. So as we all know, thinner the cornea, more abnormal it is. So a cutoff of 470 to 480 and anything below it certainly would give you a red signal. So not only the thinnest pachymetry, but the overall distribution is extremely important. Look at few distribution patterns, like your thinnest pachymetry should not be lesser than 10 microns of your central pachymetry, and the superior inferior asymmetry at the 4 mm should not be more than 30 microns. And so also between both your eyes, the thinnest pachymetry difference should not be more than 30 microns. So these are few other important values to be noted. And migration of the thinnest point is again could be an early sign of keratoconus. So make sure the thinnest location is not suspicious if it's more than 500 microns from the center, and it's certainly a sign of keratoconus if it is 1 millimeter away from the center. So here you have a thinnest point more towards the center in your left cornea, which is normal, and in the right cornea it is close to 1 mm away from the center, which is a sign of keratoconus. Now let us end the presentation with this analysis of this map. So if you look here, there is a huge elevated area on the back surface and the same point is highly thinned on the pachymetry. So is it a case of keratoconus? Not actually. So this is a patient who had an injury with a corneal scar. So scars are true mimickers of keratoconus. So it's very important you look at all the 4 maps and your red flag spot should be in the same spot. And also before interpreting or analyzing any scan, it's very important you do a good clinical examination. So without a clinical correlation, none of these examinations have a true value when it comes to treating the patients. So thank you, and I would want to leave a message of the Pentacam truly has revolutionized today's corneal diagnostics and how we look at the cornea. It's an extremely repeatable and reliable scan, and certainly today's gold standard. And I hope with this 6-step guide will surely help the beginners to utilize this wonderful technology to the best possible extent. Thank you so much.
Thank you for the wonderful presentation, Deepthi. To add a few more points, I would like to see the ART max, embrasure relational thickness for the keratoconus screening. Anything which is less than 330, I consider it as a keratoconus. 330 to 380 is a suspicious, and more than 380, almost no keratoconus. And also the progression index, which helps in screening for the keratoconus. Thank you.
Thank you, ma'am, for the map and come to at least a provisional diagnosis in our case. I would next like to call upon Dr. Ellen Kumaran, sir, Medical Director, Navashakti Netralaya, who would be discussing on the keratoconus management.
Thank you. At the outset, I would like to thank Dr. Nagaraju, Dr. Srinivas, and all the others who prepared this wonderful target exam for the PGs and the beginners. And thank you for giving me this talk also. All of us know that keratoconus is described or defined as a progressive thinning of cornea leading to ectasia. But say a few years back, we always considered this to be non-inflammatory. But then, of late, we know that there is an inflammatory component also to this. So this is the change in the definition as well as the etiology. If you look at how this refractive surgery, and when we talk about refractive surgery, there's one thing that we want to avoid, that is keratoconus is evolving. These are the tests that has been done. But if you carefully see, it's from the early 2000s that we have improved in keratorefractive surgery as well as in the diagnosis of keratoconus. So how do we decide this progression? Dr. Deepthi spoke beautifully about the topographical indexes, the Pentacam indices, and all other things. But 3 things, particularly when you start your practice, please remember 3 things. Number 1, patient comes to you where your retinoscopy or your AR readings is not matching the spectacle prescription. A sudden increase in the spectacle prescription, particularly in the teenage group, that's how you make it clinically and by refraction wise. And most importantly, if you're good with your retinoscopy, if you're unable to neutralize the mires, that is, neutralize the reflections, that is the time you think that there is something wrong with the cornea, some irregularities there on the cornea. Of course, we have our investigations to support as we grow. Gold standard, of course, is the topography. We started off something like this with the Placidio and later moved on to OpScan and now Pentacam. Pentacam is supposed to be the gold standard as of now. Dr. Deepthi beautifully elucidated what are the findings. What is not covered in this particular session, I would like to touch upon this. Next is corneal biomechanics. Now, what is this corneal biomechanics? Any tissue, any object, any material for that matter, when it is subject to a force, it undergoes some amount of deformation. And it tries to recover from this deformation. The time lag that it takes is what causes what is called as a what resists this is called as a biomechanics. In the cornea, if you apply a force, this is the first thing that was put forward, corneal hysteresis. If you apply a force, the cornea bends, gives some space, retains that immediately. Once the stimulus is removed, it retains that shape for some time and then comes back. This is the period that is measured in most of the investigations that we are doing right now, called the corneal, the inward applanation point, the outward applanation point. This is considered to be the corneal hysteresis. This is measured. However, when you look at a normal cornea, I showed the normal cornea, but if you look at anything that causes thinning, be it keratoconus, post-LASIK ectasia, or plain post-LASIK, you can see both the amplitude and the time duration is enlarged. That's how you make up. Now, that was only a static thing that, being recorded at 2 different points of time. However, with an ocular score is a dynamic, where air is pushed in, the deformation of the cornea is noted, and then this is calculated. So these are the 2 exciting new technologies, exciting from quite some time, which have been coming out. What is the difference? Corvis reports deformation of the cornea. It is a dynamic thing, while this is a static. It just records at 2 places, while Corvis records at multiple places. Advanced mathematical modules can be applied so that a formula can be obtained, and then we are waiting for this still. Now, how do we go about managing these cases? Anything to do with vision, we always start with glasses. Yes, early keratoconus can be treated, can be corrected with glasses. If there is more surface asymmetry, then we go to contact lenses. And if that was not fitting properly, or if the vision was not good, then we used to think about transplant those days. However, there are certain things which we have developed of late. Traditionally, what we were taught was anything where we cannot make the patient improve beyond 612. Say glasses is not improving beyond 612, shift to contact lenses not improving beyond 612, shift to. This is what was taught. But what is practically done is, if that vision, whatever we give with glasses, is not helping him perform his daily duties, then we shift him to contact lenses. Or if that contact lens is not helping, then we shift him to the other procedures. But then we always told that this is a progressive disease. So in a progressive disease, what is the first thing we have to do? Stop the progression. What is the second thing we have to do? Try to improve the vision. From 2005 onwards, we had a technique to stop the progression as such. Now, what is that thing? So let's see what are the options we have in treating keratoconus. Number 1, stop progression. The only thing that's available there is corneal collagen crosslinking. Previously, we used to call it C3R, now we call it CXL. To a certain extent, that irregular astigmatism. Now, here we are only stopping the progression. Whatever surface astigmatism that is there, to a certain extent, can be reversed with intracorneal ring segments. And this cornea is thin. So, if none of this is possible, or if a scar is there, then we go ahead and perform a transplant. A few years back, it was only penetrating keratoplasty, and we used to go around claiming that almost 95% success rate with penetrating keratoplasty. With the advent of component corneal surgeries, we have come to the point where we just treat the tissue or part of the tissue that is defective, that is pathological. So this deep anterior lamellar keratoplasty came into vogue. Many techniques are described in a deep anterior lamellar keratoplasty, of which most important is the big bubble technique. Now, along with this, in the last 5 to 6 years, there have been certain other exciting techniques which came out. Tissue deletion. Now, what is this tissue deletion? We'll be explaining in detail, or tissue addition. Tissue deletion is to remove some amount of tissue so that the irregularity is better. And tissue addition is such that this is a thin cornea. So why not add a tissue, something like a dal, but instead of a dal, here we are adding it in between the surfaces. 2 different exciting things. I have not added slides for this, so I'll explain. Lenticular insertion, it was one of the pioneers is here in Bangalore, Dr. Sri Ganesh. What is done is the cornea part, which is either from the donor or nowadays from what is obtained from the smile tissue. Donor is better because you can get a thicker lenticule, is shaped, and a pocket is created in the cornea of the keratoconus, and then this is inserted so that there is thickening, and this maintains. Over and above that, there is a corneal crosslinking that is done. Now, I would like to concentrate more on this aspect. This is the only technique as of date available to stop the progression of keratoconus. Classical is the Dustin protocol. Always, the thing is, there is epithelium removal, and then instill riboflavin drop, 1 drop every 3 minutes for 30 minutes, and then UV light 365 nanometer exposure at 3 millivolt per centimeter square, during which time continue the riboflavin 1 drop every 5 minutes, and then wash with linger-acted, and place a bandage contact lens. This was the classical dressing protocol. There were various variants that came out of this. Transepithelial, that is without removing the epithelium, that went out of work very fast, and something called the accelerated cross-linking. But before going to that, let's see what the riboflavin and the procedure does. We add riboflavin, along with that use this particular 365 to 370 nanometer of light. This creates photoexcitation. There are certain bonds which are present in the stroma of the collagen in the stroma. Now, the photoexcitation of the riboflavin molecules release oxygen radicals, which creates cross-linking between those bonds. If the cross-linking is more, it can cause a scar and reduce the vision also. How do you find out that this cornea is cross-linked? The classical thing to find out that this cornea is cross-linked is to observe the demarcation line. What we talk about, it is seen on an OCT, but it is also seen clinically in the first 3 to 6 months after the corneal collagen cross-linking. When should we do it? Remember, the young patients, again, there's another slide for this later, but the young patients do it earlier. For slightly elderly patients, monitor progression, then do it. Why do we consider 400 microns as the least? Remember that during the procedure, there are evaporative losses which thin the cornea, and this 0.18, whatever we use, that can cause damage to the endothelium, hence need for 400 microns. But having this definition, many of the patients present to us, this 400 microns is after removing the epithelium, please remember this. Many of the patients present to us with lesser corneas. So what do we do for this? Various methods have been told, but two different things which we have been using in the practice and easier to do is iatrogenic corneal swelling before cross-linking. How do we do that? Special riboflavin, hypotonic riboflavin is available. Use that so that the cornea thickens and then the corneal cross-linking can be done. The other option is to use a contact lens assisted corneal collagen cross-linking, which is described by Susan Jacob. But the only thing to be taken care of is you have to choose a contact lens which does not filter the UV light. There are lenses available for this. Now, how long should we do it? When it came, it was just said that 5.4 joules per centimeter square was what was required. Total energy was required. It would be given as 3 millivolt per second squared for 30 minutes, or reverse it, 30 millivolt per centimeter squared for 3 minutes. But this accelerated had a lot of advantages because the patient lying down on the bed for 30 minutes looking at a light, particularly a young patient, is usually uncooperative. But then what we started noticing was this accelerated hypertension. There are various protocols, just like how I was telling. The accelerated corneal collagen cross-linking did not have the desired effect as much as the traditional trusted protocol. So a balance was obtained wherein 0.1% with 20% extra, riboflavin 0.1% with 20% extra, usually given over a period of, sorry, I marked the wrong thing here, usually given for 10 minutes, 9 millivolts, yeah, sorry, correct, 10 minutes, 9 millivolts, 10 minutes is what is practiced by most of us. And look at this column here, the riboflavin impregnation. It should remain between 20 to 30 minutes. So even if you're doing the accelerated corneal collagen cross-linking, remember that at least 20 to 30 minutes of soaking should be there. What is the right way to find out? After this riboflavin soaking, take the patient on the slit lamp, look for the fluorescence in the AC. That's the right way, but many of us don't do that. We presume that 20 to 30 minutes is enough. There are various other dyes available, of which the exciting is rose bengal dye. Nothing has been tried clinically. Clinically, the only thing that is available is riboflavin. Now, I said 400 microns there and 300 microns here. Even till 300 microns, we can use the thin cornea protocol and cross-link these corneas. These are the other indications where corneal collagen cross-linking is not indicated or should not be done. Now, what are these combined procedures? The most combined procedure is INTAX, wherein during the cross-linking, first put in intracorneal segments, so that the cornea stabilizes. These have a volume adding effect. It does not stretch the cornea. It has a volume added effect so that the cone is shifted centrally. Volume added effect peripherally, cone is shifted centrally, makes it more symmetric, makes it more regular. That's what this does. And these are the patients whom you can think about an intracorneal ring segment. In short, if I have to tell something here, an intracorneal ring segment is for a person who has an irregular keratoconus. Asymmetricity is more. However, it can be used anywhere to bring the cone to the center. We have different types of ring. In the first case here, we can use a symmetrical 2 rings. In the second case, we have to use asymmetric or a single ring. Point to be noted, it has to be kept at least 2/3 the depth, 70% of the depth for it to act. And after finishing the surgery, immediately look for this depth. Many of us use a femtosecond laser nowadays. However, previously we used to use manual, we used to create the thing manually. So those days we had to see it immediately so that we are not very anterior or posterior. The other combined procedure, how about doing a laser on this cornea? Traditionally, we have been taught that this is contraindicated. Yes. So how does the laser work? The only thing it does is removes the surface irregularity. We are not treating the power here. Remember, we are just making it regular and doing a cross-linking. Somehow I'm not very comfortable with this procedure. Anywhere above 450 microns only, or 470 microns, I would dare to touch this procedure, and that too only in suspicious keratoconus after explaining the problems. This is what it does. The surface irregularity reduces. LASIK extra is something which many of us have been avoiding. What it means is in suspicious and keratoconus form of patient, you can still do a refractive correction, but simultaneously do a corneal collagen cross-linking. Now, there is a keratoconus patient in front of you. What are the things you have to do? Number 1, assess whether it's progressing or not. Number 2, whether contact lens tolerant or not, so that you can prescribe a contact lens. Plan to arrest the progression, do a CXL, and then go ahead for visual rehabilitation. If all else fails, surgical methods are always there. Preferred is talc. So these are the high risk for category for progression published by Narayana. You can just have a look at it. If I have to decide something here, 2 things. One is age, less than 20 years. I would like to cross-link this patient on first diagnosis itself, and associated with rubbing, definitely eye rubbing, and any other inflammation that is associated. Treat the inflammation, go ahead. So how do you decide it? Look at a keratoconus patient. Are there any high risk characteristics? Then go ahead and directly cross-link this patient. No high-risk characteristics, less age, wait. Wait for progression. If progression is needed, again, go ahead and cross-link this patient. If progression is not there, you can just prescribe a contact lens or other modalities of visual rehabilitation. But point to be noted, watch this patient, serially follow it with topography, preferably pentacam, but otherwise, any of the topography measures that you can see, do a proper clinical evaluation and refraction, follow these patients. When you do a cross-linking, you have 2 options. Do only a cross-linking, central cones, less irregularity, you can just do a cross-linking and give a glass prescription. Irregular cones, asymmetric cones, displaced away from the center, better to use a intracorneal ring segment along with cross-linking. If all else fails, we have lamellar keratoplasty or penetrating keratoplasty. 1 point to be added here, lamellar if there is no scarring, penetrating if there is scarring. Thank you for the opportunity that's given. One thing I missed out, nowadays we also use ICLs. Indication for ICL usage, I would say, is a stable keratoconus with a decently regular cornea, a central cone. Whatever it is, an eccentric cone, irregular corneas, please do not use this ICLs. Thank you for providing me the opportunity.
Thank you, Ilan Kumar. It's a wonderful talk. You have explained in detail
Yes, sir,
about the keratoconus and its management. To add on to it, see, we have a wide variety of treatment modality from the glasses, contact lens to up to the Bowman's transplantation. So I advocate, I prefer managing the local inflammation and causes of keratocyte. That is not been highlighted much, because they are only highlighted on the treatment, but they're not much about the. So I want to manage the local inflammation with whatever available immunosuppressants and manage the patient with the basic contact lens, that is, and collagen crossing. That's prioritized. Then go for a surgical modalities.
Okay. Yeah, definitely. I agree with the point. The first thing that has to be considered is to treat the clinical inflammation. Even if there is no clinical inflammation, I would like to give at least cyclosporin and lubricating drops to these patients, and with a strict instruction not to rub the eyes.
The basic pathology is your local inflammation and the keratocyte apoptosis. So that should be addressed. Okay, thank you, Ilan.
Okay.
I would like to thank Dr. Ellen Kumaran sir for that extensive talk on the management of keratoconus and an algorithmic representation for every PG, which will help them get through that very difficult topic for us. I would now like to move on to the next speaker, Dr. Tanuja GP, who's an associate professor at Ramaiah Medical College, who will be addressing the talk on keratoplasty, the types and techniques.
Hello everybody, I'm Dr. Tanuja and I'll be talking about keratoplasty types and techniques. So I'll just share my slides. So if you look into the keratoplasty timeline, you see that up till 1845, keratoplasty was only being conceptualized, was thought possible. Then a lot of trials and errors and techniques of lamellar keratoplasty became popular. But between 1905 to almost 1995, penetrating keratoplasty became well established, and it was a golden age of penetrating keratoplasty. But after 1996, there's a re-emergence of lamellar keratoplasty because many of us have realized that we don't need to remove tissue which is not abnormal. Okay, only abnormal tissue has to be removed. So after 2010, really, I mean, it's been a golden age of posterior keratoplasty because there have been various modifications in posterior lamellar keratoplasty. So we all understand this. If it's a full thickness penetrating keratoplasty, stroma, anterior lamellar keratoplasty, Descemet's up till the Descemet's membrane, deep anterior lamellar keratoplasty. On the stroma, with the endothelium only transplanted DSEC or DSAC. And if it's a Descemet's membrane alone transplanted, it is Descemet's membrane endothelial keratoplasty. So indications are very obvious. If there's a full thickness corneal opacity with abnormal endothelium, then you do penetrating keratoplasty. But if the endothelium is normal, then you do a DALK. Okay, if the stroma is clear and then the endothelium only is abnormal, then you do endothelial keratoplasty. Now coming to superficial anterior keratoplasty, if the indications are any superficial anterior stromal opacities or stromal dystrophies, where you would want to remove only the diseased cornea. So it can either be done by manual dissection, but then the interface haze is high because of irregularities in the surgical dissection, so it's no longer done. So it's usually a microkeratoma assisted, a free cap is removed. The same thing is done on the donor cornea and then it is transplanted. Or it can be used with a femtosecond laser assisted also. The complications, however, are residual corneal pathology, interface haze, dry eye, and anisometropia and epithelial growth. Deep anterior lamellar keratoplasty has been used, been the whole of 1996 and probably the first decade of 21st century has seen a lot of modifications and has become well established for all corneal stromal opacities, stromal dystrophies, and keratoconus. It has revolutionized the management of keratoconus. So what are the types of techniques? There are various techniques. It can be a direct dissection where you use air to loosen the stroma and then dissect it out, and at multiple levels where direct dissection is done, but then remove the Descemet's membrane and transplant it. But obviously it takes time. There are risks of perforation. So Malaise came up with a technique where he injected air into the anterior chamber and using the reflexes between the air and the stroma, he was identifying the Descemet's membrane. But big bubble technique has been a revolution in lamellar keratoplasty, and it makes the procedure faster and easier. Okay, but now with femtosecond, everything else seems very easy. So femtosecond discerns the layer and then it's very easy to do the dissection and complete the procedure. But the complications are astigmatism, and there's always an interface. Here you see this case of keratoglobus where we did a lamellar keratoplasty, and there are a lot of Descemet's folds, and the patient will have some glare. But the advantages are there's no endothelial rejection and reduced complications of open globe surgeries like expulsive choroidal hemorrhage or infection. Post-lamellar keratoplasty, there have been various modifications. Initial stages, Melle started with removing, making a anterior stromal flap, taking out the endothelium, and then transplanting the endothelium and suturing it, but that was thought to be cumbersome. Then deep endothelial keratoplasty was done, where a stromal pocket was made and the deeper endothelium and stroma was dissected out. That was also found to be very difficult. Then came the Descemet's stripping endothelium, where in the recipient only the Descemet's membrane is stripped, but on transplantation of the donor, along with the Descemet's membrane, some amount of stroma was transplanted. Using a microkeratome for preparation of the donor cornea, it became DSEC. Then with pre-cut donor tissues, ultra thin DSECs came into picture. For femtoseconds, laser-assisted DSECs or femtosecond and excimer laser-assisted EKs became very popular. Then they realized, why do you even need stroma, because it was causing more rejections. Then came the Descemet's membrane endothelial keratoplasty, where only the Descemet's membrane is removed in the recipient and only the Descemet's membrane with the endothelium is transplanted onto the from the donor onto the recipient. But since the tissue was very thin, there were modifications to this also with a stromal rim. It became called as DMEC. Yes, femtosecond can be used to prepare to enable the descemetorexis. Or nowadays, there's no transplantation, only Descemet stripping is being tried with or without ROCK inhibitors, when without any endothelial keratoplasty. So basically, if the peripheral corneal endothelium is good, the cell density is good enough, then it is expected that these cells will migrate to the center and clear up the cornea. And Descemet's membrane endothelial transfer, what is done here is, it's not completely attached, but it is expected that these detached, not incompletely attached cells will migrate and cause and fill up the area. But again, this is of doubtful hypothesis, because many DMECs which have not attached well fail to show that there is a transfer of endothelial cells, but only time will tell us as we see and follow up these cases. So the risk of graft failure in DMEC compared to DSEC is actually less. The range of failure is from 0 to 12.5%, but there is a high risk of pupillary block and increasing IOP, and which can be managed if the patient surgeon is well aware. Again, the 5-year survival rate is quite good compared to DSEC, which is almost 90 to 96. It has a steep learning curve, but once it is learned, it has a very good results. DMEC gives very good results. Now, all said and done, has penetrating keratoplasty lost its charm? Not really. In India, it is not very rare to see such kind of cases. They do come with such cases, such conditions, and we need to do penetrating keratoplasty. So penetrating keratoplasty still has its role, and though the chance of graft failure, graft rejection, secondary glaucoma, astigmatism are all high, they do give good results, and sometimes they're the only things possible for our patients. So thank you very much.
Thank you, ma'am. Just to add on a few points. In the exam, when a case of post-keratoplasty has been given, usually the most common scenario would be a corneal dystrophy in the other eye. Could be a granular lattice or a macular dystrophy. Usually granular and lattice 8K anterior lamellar keratoplasty is done. For a case of macular corneal dystrophy, DALK can be attempted, or sometimes you may have to go in for a full thickness optical keratoplasty. In a case of an eye which is post-keratoplasty, a proper corneal drawing has to be done, indicating the sutures, whether they are interrupted or continuous, whether the graft is clear or there are any signs of rejection, and also how is the opposition at the graft host junction has to be clearly noted. Thank you.
I would like to thank Dr. Tanuja GP for that extensive talk on the transition of keratoplasty through all these years. Thank you, ma'am. I would now like to call upon Dr. Kiran Kumar K, Assistant Professor at Minto Ophthalmic Hospital, for his next talk on evaluation of a case of refractive.
Good morning, everyone. I'll be discussing on approach for refractive surgeries. Yeah, refractive error is a condition where like parallel rays of light entering the non-accommodating eye do not focus on retina. It could be either like focusing in front of the retina in cases of myopia, or behind the retina in hyperopia, or even it could be astigmatism. So refractive errors can be easily managed by spectacles or contact lenses, but in some cases where patients are not willing to wear spectacles or contact lenses, we can go for refractive surgeries. It can be like broadly classified into based on like cornea-based procedures or lens-based, or combining both cornea and base, that is called bioptics. Corneal-based procedures also, there are many techniques to tackle refractive errors, and the few are like the LASIK, that laser in situ keratomyelitis, or it can we can also go for surface ablative procedures, that is PRK, epilastic or LASIK, or the most recent and advanced technique to correct myopia is small incision lenticular extraction, or even you can consider for intracorneal ring segments or intacts. Lens-based procedures are usually considered in the patients who are not fit for corneal-based procedures. It could be either a phakic or even you can consider refractive lens exchange. Bioptics is a technique when there is like too much of refractive error and we cannot correct based on only one cornea or lens-based procedure. We usually combine these two to correct the maximum refractive error. I'll just give a scenario for choosing the correct option. Usually, that refractive error correction by refractive surgeries is approved by US FDA for up to myopia of 10 diopters, with hyperopia of 4 to 5, with astigmatism of to 4 diopters. And pachymetry, there should be like enough for the residual bed thickness, which is usually like more than 250 microns, and keratometry ranging from 40 to 47 diopters. And if there is no any ocular surface disease and not having any form of keratoconus or in the corneal topography, and if age is more than 18 to 45 years, like what do you have to consider? This is like a classical the case for undergoing any corneal based procedure. It could be either smile or LASIK, but however, like not every eye fits into all procedures. It's usually customizable based on patient requirements and patient corneal topography and other additional factors. So it is usually a dynamic decision, and each patient should be assessed individually on various parameters. And this is one more option, like wherein we have a thin cornea of about 480 to 500 microns with very low myopia up to 3 diopters and normal topography and occupational requirements like police and aircraft. They usually, in occupational requirements, they don't consider if a patient has undergone any flap-based procedures. So these cases, we can easily go for surface ablations like PRK. But the main disadvantage of this PRK is like there is no wow factor on the post-op day one, because it usually takes up to 8 to 10 weeks for the patient to have best corrected visual acuity of 6 or better. And there are chances of developing gaze, and even there could be a regression if we treat higher refractive errors. And what about the cases like which have high refractive errors and residual thickness of only 250 microns, and there is like some amount of ocular surface disease, and do we call them as LASIK rejects? For them, the main option is phakic IOL. Coming back to the pre-op evaluation, as I told you, like FDA, US FDA has approved by for correcting of refractive errors by most of the techniques. That's cornea-based surgeries is only up to minus 10 diopters, and hyperopia of about 4 diopters, and astigmatism up to 4 to 5 diopters. There's some of the like absolute contraindications which you always should remember before taking any patient into consideration for refractive surgeries. The most common is corneal ectatic disorders like keratoconus or PMD, and even patient who has thin corneas about 480 microns and refractive instability, and if there is any active ocular infection and the severe ocular surface diseases and glaucoma, scleritis, and pregnancy. There's some other like absolute contraindication wherein we should not pitch in for refractive surgeries. And there are few relative contraindications like collagen vascular diseases and diabetes, and it should be well controlled before considering any patient for refractive surgeries. And active blepharitis and meibomitis has to be treated, and there should be interval of about at least 4 to 6 weeks of silent eye before considering any patient for refractive surgeries. Pre-op evaluation. The most important thing here is the age factor. Like there are a lot of like considerations here, whether we should, what age is ideal for undergoing a refractive surgeries, because many patients will be eagerly waiting either to cross 18 or 21 so that they want to undergo refractive surgery. So the main thing here, instead of considering 18 or 21, one factor which I always do consider in my refractive surgery patients is like refractive stability for at least 1 year. There should not be change of even the 0.5 diopters in the refractive error after 18 years ideally. And contact lenses. See, most of the patients of this refractive surgery, who opt for this refractive surgery, will be using contact lens. Either it could be soft or RGP lenses, but these soft contact lenses induce some degree of topographical pattern of corneal steepening, and also it causes increased cecity after discontinuation up to like 20%, 20 microns in 90% of the cases. So ideally, it's better to advise patients to stop using soft contact lenses at least for 2 weeks, and for RGP, ideally, you have to stop at least for 3 weeks to get back to the normal cornea. And pre-op evaluation, there's some of the medications which usually interferes with the healing in post-operative period, like isotretinoin, amiodarone, and very other immunosuppressants. And this should be kept in mind before considering for any surgery. This is the list of drugs. Coming back to the visual acuity, the proper documentation of the uncorrected, best corrected is very much important. And then slit lamp microscopy to look for any ocular surface instabilities, and tear film analysis, and corneal vascularization. Most of the patients who wear the contact lenses, they'll have like peripheral limbal vascularization that will interfere, especially while docking, and there might be bleeding from these results. It leads to more stronger healing response and thereby regression in cases of surface ablative procedures. And pupil size. Pupil size, ideally, I consider like 4.5, the mesopic pupil size. Why is it so important? Optical zone, which we plan during surgery, ideally should be planned according to the mesopic pupil size, because the functional optic zone, which we consider, is usually about 25% less than ablation diameter. So laser should be planned in such a way that FOZ should be more than the mesopic pupil size. Fundus examination. Emphasis on the peripheral retina screening by direct ophthalmoscopy is one of the most important step in refractive surgery evaluation, because most of the eye myopes, they'll have some peripheral treatable lesions which might need laser augmentation, a barrage laser, or even cryotherapy. In those cases, you have to consider for refractive surgeries at least 6 weeks after such procedures. And topography. And topography evaluation for the refractive surgeries has been discussed with the previous speaker. I'll just skip it for as of now. So to summarize this pre-op evaluation, uncorrected and best corrected visual acuity, because is the most important thing which helps to predict post-operative outcome and realistic expectations. Suppose a patient is having like 6-9 BCVA in both eyes, you cannot expect them to give 6.6 or 6.5 in post-operative period, and which needs to be counseled to the patient properly. And manifest refraction by cycloplegic and even the cycloplegic refraction. Okay, ideally, all patients of refractive surgeries should undergo dilated cycloplegic refraction, and we have to repeat an post-pediatric test after day 1. Okay, so to get the sharpest visual acuity with least amount of minus is the final endpoint in subjective refraction. And vertex distance is also an important factor for the people who are wearing the spectacles are more than 5 to 6 diopters, and even ocular motility to make out any latent squint, because some of the patients will rather develop a squint post-operatively. Some patients like accommodative isotopes. And even ocular dominance has to be tested, especially when we are considering like monovision or even in patients of rest beyond. Intraocular pressure. See, intraocular pressure is one of the most important factor. There'll be like a slight increase for a fraction of a second during the docking while performing LASIK or spine surgery. And even post-operative period, most of the high myopes, they could be like steroid responders. So pre-op intraocular pressure monitoring is a very essential step in refractive surgery. And even TFLM assessment by Shermer's, Tibet, and Corneal staining because dry eye will worsen after keratoplasty surgeries like LASIK and PRK or SMILE. But we do see like less chances of dry eye in post PRK and even SMILE cases. And slit lamp examination to check for all adnexial and eyelid abnormalities and conjunctival scarring, to see for epithelial any epithelial basement membrane dystrophies, and even minimum lenticular change should be documented and informed to the patients. And as I told you, like dilated fundus examination to look for any peripheral treatable lesions. So pre-op, this is some of the investigations which needs to be done, especially the forcimeter of the spectacles and also the pupillary size. As I already told you, this is like very important, especially while considering the optic zone. It should be larger than the pupil size to minimize glare and halos, which will be very troublesome for the night driving. So people who have an ideal size of about like 4.5 mesopic is considered to be like best responders. The people who are having like more than like 5 millimeter, they usually complain of glare and halos in post-operative period. And keratometry. Keratometry, we usually nowadays, even though the ultrasound pachymetry is still the gold standard, but we do consider the pentacam in pre-op evaluation because there's some other things we have to see in pentacam is the central corneal thickness. Considering of any corneal-based procedures, ideally the corneal thickness should be more than 480 microns. And there's a few checks here like restral stromal bed thickness and even percentage of tissue alteration. This is the two main important factors which decides whether we have to consider for surface ablative procedures or lenticular based, or is a patient fit for refractive surgery or not. Always a residual bed thickness should be more than 250 microns after any of the refractive corneal based procedures, and percentage of tissue alteration in the cornea, it should not be more than 40%. And if it is more than 40%, those patients may develop a post LASIK or SMILE ectasia. So the topography, one of the like main investigations in refractive surgery. For now, I'll skip this off because this has already been discussed by the previous speaker. Yeah, patient and surgeon should have a realistic expectation from refractive surgeries. So see, usually whenever we do refractive surgery, it hardly takes about like 3 to 4 minutes to complete a case. But what we tell and how we counsel the patient is going to stay with him for his lifetime. So ideally, all the patients should be told about the realistic expectation from refractive surgeries, and inappropriate and unrealistic expectations are the most common cause of dissatisfaction in patients. Thank you.
I would like to thank Dr. Kiran Kumar sir for his wonderful talk on the evaluation of a case of a refractive surgery. I would also like to thank all the speakers who have participated in the cornea module for highlighting all the key points in every case that would be required by a postgraduate in dealing with all the cornea cases, be it a short case or even a long case. Thank you, one and all.